Dr. Brian Kaufman, the Chief Medical Officer, Executive Vice President of the CLL Society here at ASH 2023.
My name is Dr. Piers Blombery. I'm a hematologist from Melbourne, Australia, Peter MacCallum Cancer Centre.
Dr. Blombery, we're going to talk about something that's not CLL but tightly related to CLL, and that's another blood cancer. And it's CLL is a lymphoid malignancy, and this is a myeloid problem. First, could you just a basic for a patient, what's the difference between the myeloid and lymphoid systems? And cancer doctors have to deal with both, but explain that to us.
Sure. So essentially, our blood is consistent of two main compartments, the lymphoid compartment and the myeloid compartment. The myeloid compartment is involved in sort of the front line, if you like, the infantry of the immune system. So they're on the front line, throwing themselves on the live grenades, on the bacteria, and that's the part that makes pus, and they're fighting on the ground. The lymphoid part is if it can be thought of as the sort of the intelligence agencies. Okay, so they're a bit more they're producing antibodies, and they're more orchestrating the immune system from afar. And so the myeloid system, which myeloid system which includes neutrophils, monocytes, eosinophils, those sorts of cells, whereas the lymphoid cells are B cells and T cells. You need both for a functional immune system, and obviously in blood cancer you can get blood cancers arising from each of those compartments. So for example, in the lymphoid compartment, if you've got a B cell which becomes malignant, that can be CLL, whereas in the myeloid compartment, if one of your myeloid cells becomes malignant, that can be acute myeloid leukemia or myelodysplastic syndrome or some of these others.
And one of these others, which isn't a cancer but sort of a precancerous condition, but it's kind of complicated, something called clonal hematopoiesis. And you've done some research with yourself and your colleagues in Melbourne.
Yeah.
At the Peter Mac. Can you explain what clonal hematopoiesis and why that's of particular interest to CLL patients?
Sure. So clonal hematopoiesis is essentially, I think of it as the polyp of the bone marrow. Okay. So as we all age, our bodies are slowly becoming more clonal. So we get
clonal means identical, right?
Clonal means a particular cell in an organ has acquired some sort of advantage which makes it outgrow its neighbours. In the bowel, that looks like a polyp. On the skin, that might look like a solar keratosis. In the esophagus, that can look like something like a condition called Barrett's esophagus,
which is like a precancerous condition.
Yeah. And all these. In fact, there's been some great research is done, which has shown that entire islands of your skin are all given rise to by one particular clone. And so this is just a natural selection of fitter and cells throughout life. Now, as you can imagine, when a cell becomes too fit, it becomes cancerous, and there's some sort of threshold by which across you can have. So clonal hematopoiesis is what happens in the bone marrow. So you get a cell, and in fact this is universal by the age of 20 or 30 if you look hard enough. So by 30 years old, you've got a couple of cells in your bone marrow which have outcompeted their neighbours. And then by the age of 60 to 70, you can detect it in about 10 to 15% of otherwise healthy people. These people don't have any problems with their blood counts. They have no health problems, but they just have their blood instead of being produced and contributed to by all their stem cells are being biased towards a couple of their stem cells. And this, as I say, it's the polyp of the bone marrow. This is potentially a pre-malignant condition, and it's not specific to the myeloid or lymphoid lineage. You can get either myeloid or lymphoid cancers arising out of clonal hematopoiesis, but it's in fact probably the basis of all hematological malignancy is arising out of clonal hematopoiesis.
And I've also heard it called CHIP, or clonal hematopoiesis of indeterminate prognosis, which suggests we don't know what's going to happen with it.
Yeah, so I mean, I was talking yesterday to someone about this term indeterminate prognosis. We have we have undetermined, indeterminate. We actually know what it does, but for any individual, we know at a population level what it does. But for any individual person, we don't know their contribution. We know their risk of transformation in someone with inverted commas CHIP to a blood cancer is approximately 1% per year. So we're pretty sure about that, but we're just not sure that for an individual person whether they will be the 1%.
Are CLL patients at higher risk? We're at higher risk because we're older, but every older patient is at higher risk. Are we at particularly higher risk, and are there certain therapies that put us at higher risk?
So as you can imagine, clonal hematopoiesis increases dramatically after you've had chemotherapy. Okay, because chemotherapy is if you like a selection pressure against the bone marrow for the fittest clones. So yes, it might get rid of the CLL or whatever other malignancy you have, but at the same time, everyone's familiar with the fact that your blood counts drop down with chemotherapy. Unfortunately, chemotherapy doesn't attack exclusively the bad cells, and so some of the good cells get knocked down, and you can imagine the ones that get knocked down the least are the ones that are the fittest. And so with successive rounds of chemotherapy, you get repopulation of your bone marrow with more and more clonal hematopoiesis, and ultimately you'll be familiar with sometimes there's a condition called therapy-related myeloid neoplasm, where people get a secondary blood cancer because of the chemotherapy they've had in the past, which we've recognised, for a century.
And this is where, like, we hear about it in celebrities with breast cancer getting treatment, and then 20 years later coming down with myeloid cancer.
Exactly right. Yep.
Okay. Are there any, other than chemotherapy, are there any other therapeutic agents? Is there? There's been some discussion about venetoclax. Is that an issue with CHIP?
Yeah, so we're presenting some work at this Congress about venetoclax and clonal hematopoiesis, and so our work, which we published previously in Blood and are now presenting here as well, it looks like when patients take venetoclax, and people may well be familiar that when you're on venetoclax, your neutrophil count can drop down a little bit, and venetoclax, and that's because the whole BCL2 pathway is actually important throughout hematopoiesis. It's important to make myeloid cells, and it's important to make lymphoid cells. And so when you give someone venetoclax, actually it puts a pressure not dissimilar to chemotherapy. Obviously it's both quantitatively and qualitatively different to chemotherapy, but it's conceptually similar, where you're providing a pressure against the blood system by which cells will try and get around. The blood system is full of rapidly dividing cells, and any pressure you apply to it, the blood cells will work out a way of getting around it. And when patients take venetoclax, their blood system develops a particular way of getting around it, called mutations in a protein called BAX.
So that's BAX. What is BAX?
Yep.
Why should a CLL patient care about BAX?
So BAX is the way, ultimately the way in which venetoclax works. So venetoclax inhibits BCL2, but BAX is the protein which sort of punches holes in the mitochondria and causes the CLL cell to die. And so if you imagine, venetoclax is critically reliant on BAX to work for it to have its effect. So if you lose function of BAX through mutation, venetoclax doesn't work. And in fact, neither do lots of other things that rely on that, so lots of other BCL2 inhibitors. And so you can imagine if you're if in a patient with CLL, if you're a stem cell which is giving rise to both myeloid and lymphoid cells, and all of a sudden you're exposed to venetoclax, it's in your interest to have a BAX mutation, because that will allow you to survive, and it will. I don't want to ascribe too much sentience to stem cells, but it's obviously a lot more complex than this. But having a BAX mutation allows that cell to survive, and then and especially in the context of prolonged venetoclax exposure, you get more and more selection of BAX mutated clonal hematopoiesis. Now the big question is that, as I said earlier, clonal hematopoiesis can give rise to, is potentially a pre-malignant condition. And that's because in the chemotherapy context, when we give chemotherapy to the stem cells, the type of mutations they develop are the sort of mutations which makes the cell generally fit and generally resistant to DNA damage, which are the sort of attributes that a cancer wants. With venetoclax and BAX mutations, there might not be actually intrinsically helpful for a stem cell to have a BAX mutation if there's no venetoclax around. And so what we don't know at the moment, and we have no evidence for, is that there's an increased risk of any cancers caused by venetoclax, and in fact the weight of evidence would suggest there's not at the moment. That said, it looks like, so in our work we've now looked at patients with acute myeloid leukemia, CLL, follicular lymphoma, breast cancer, so venetoclax is being used for patients with breast cancer, and in all these patients we've found about a 30 to 50% incidence of BAX clonal hematopoiesis in the context of venetoclax use.
And is that even with a fixed duration, like a short-term use?
Yes, it is. So it's different in different contexts. So in breast cancer, it was long term, and the CLLs was also long term. But in AML, it's given in bursts once a month with chemotherapy, and that may be a unique situation where you're sort of both giving venetoclax and as well as wiping out the bone marrow. But there's actually there's hopefully some work coming out, and we're working on analysing some trial cohorts from upfront patients with fixed duration therapy, where we can work out how common this BAX phenomenon is. No doubt it'll be more common in patients who are, with all this work, the first patients you observe these in are the patients who are relapsed refractory, have had the most lines of therapy, and in this particular work, you can imagine they've got the most amount of clonal hematopoiesis and clonal complexity coming in, whereas it may be very different in patients who've never had chemotherapy before, who only have a year of venetoclax.
Any final thoughts on this complicated but really important subject?
I think it's a good example of how important. And it's an exemplar of how important the BCL2 is across the hematopoietic system. It's
the blood forming system.
The blood forming system, and it's I think it's a question of watch this space. There's it's also suggests for in other drugs, we should maybe be looking for similar types of clonal hematopoiesis.
Well, thank you very much. I think this is incredibly important research, because what's happening is we're living longer and longer with CLL. We're doing better and better, but we're dying of second malignancies, and that's a real concern. And knowing about that and what we can do to mitigate those risks is so important. I'm so grateful for the research you're doing. Thanks so much.
Great. Thanks for having me. Cheers.